Dr. Professor Vitull for arranging a meeting and completing almost 10 years, a decade of MAPICON. And this is lovely, auditorium, lovely place to be here. And I must say, this is a boon for the Bathinda as such. Lovely place. I liked it so much that I was so impressed by the building, by the structure, and this auditorium. Great. It's not there even in Ludhiana. So, very nice. So, I will be talking about GDM. That's a, quite common. We discuss it so many times. And I think I will be clearing some matters on GDM in my own style and my own manners. So, what is GDM? So, let's talk. What is GDM? GDM is impaired glucose tolerance. It is not diabetes. It's a impaired glucose tolerance. So, this is should be very clear, because we always think GDM is synonymous with diabetes. It is not so. In fact, it is an impaired glucose tolerance which is occurring in pregnancy. So, if blood sugar is more than 126 fasting and more than 200 in pregnancy, we call it a diabetes. So, we don't call it GDM. So, this should be very clear. Number one, GDM is impaired glucose tolerance characterized by an increased risk of large for gestational age, birth weight, and neonatal and pregnancy complications, and an increased risk of long-term maternal type 2 diabetes and abnormal glucose metabolism in the offspring. So what it anyway says is that impaired glucose in pregnancy can lead on to changes in the imprinting in the offspring. He will get diabetes with the in later age, as well as there are complications, perinatal complication like microsomia and fetal distress and all those things, which I will be talking later on. Now, these associations were with maternal oral glucose tolerance test. Results are continuous. There is no cutoff value. The lower value is better. If you go to the higher value, even in the impaired glucose tolerance stage, even in the higher ranges, there are chances. So there is no cutoff value that at this value there is no complication, at this value there will be complication. This is a continuous type of thing. Higher the values of glucose, higher is the complication rate. This is just to, although this is not part of GDM, but just to say hyperglycemia in pregnancy, because many times you are not aware what to label this patient. So the recent classification is you divide into two parts. One is pre-gestational diabetes. That patient is non-diabetic. She may be type 1, type 2 or other types of diabetes. That is pre-gestational diabetes. Then comes the hyperglycemia in pregnancy. Now, hyperglycemia in pregnancy means blood sugar high in pregnancy. So, it can be, diabetes in pregnancy. When the blood sugar crosses the limit of, diabetic, it comes into diabetic range. That means more than 126 fasting, more than 200 plus symptoms of diabetes. This is a diabetes. So, diabetes in pregnancy, or WHO used to call it previously as over diabetes. And another is GDM, that's gestational diabetes. Now, gestational diabetes is when glucose tolerance test shows that blood glucose are raised in the impaired glucose tolerance range. So, it's further subclassified now, early GDM and late GDM. Late GDM is occurring at 24 weeks plus minus, right? That's the time there is increased insulin resistance. And early GDM is, there are studies which show that glucose tolerance test done in the first trimester, it also raises the risk of maternal as well as fetal complications. Although there's no studies till date for the early GDM, but this term, the fact is that higher the glucose values in the first trimester, more the chances of fetal and maternal complications. So what we are talking today is standard GDM. That's a standard GDM which occurs in the close to end of the second and start of the third trimester. So what happens to glucose metabolism in pregnancy? Now, early pregnancy, estradiol and prolactin stimulates beta cells. So there is a proliferation of the beta cells, insulin sensitivity same, but peripheral glucose utilization, there is a fall in the blood glucose levels because of insulin going high, there is more of insulin present. But in late pregnancy, what happens in late pregnancy? Fetoplacental unit extract glucose and amino acid fat is used for mainly for fuel metabolism. Insulin sensitivity decreases progressively up to 50 to 80%. So late pregnancy is characterized by insulin resistance, right? Early pregnancy is there is insulin sensitivity. Late pregnancy is insulin resistant state, and this insulin resistant comes from the fetal placental unit hormones as well as maternal hormones. Variety of hormones are implicated in that: human placental lactogen, placental growth hormone variant, cortisol, prolactin, and of course estradiol and progesterone. So these are the hormones responsible. This is the diagram I want to focus. Now, if you see the dotted line, what it says, normal insulin, pattern, what happens? In pregnant female, insulin resistance remains almost, or it becomes lower in the first trimester of pregnancy. Up to 20 weeks, it is almost the same. There is a dip in the insulin resistance at 12 weeks, at 3 months. Thereafter, there is a rise in insulin resistance. You can see dotted line over there, which tells us that there is insulin resistance, and it increases to 2 to 3 times normal. By the time we come to 35, 34 weeks, 36 weeks, it is 2 to 3 times of the normal. So thereafter stabilizes, and after delivery it falls down abruptly. So that's what happens. So just think of it that if one has a beta cell dysfunction, this 200 or 300 times production rate will not be there. It can't counter the insulin resistance. So one will develop the impaired glucose tolerance. So this is a relative insulin deficiency which occurs in patients of GDM. So initial phase is that is a good insulin secretion. This is normal pregnancy. And later on, there is insulin resistance. If beta cells are quite robust, or they are secreting, they have enough numbers and secretory functions normal, they will overcome this resistance and glucose profile will be normal. But if they have some dysfunction, then what happens is we have impaired glucose tolerance. We call it as GDM. So complication of hyperglycemia during pregnancy, what happens to mother, what happens to child, and perinatal complications child in the newborn is macrosomia, hyperbilirubinemia, in offspring neonatal hypoglycemia. For mother, it is a eclampsia, cesarean section, risk of stillbirth, shoulder dystocia, and preterm delivery. And later on in life, child may have obesity, diabetes, delayed motor development, and for the mother, there is type 2 diabetes and premenopausal breast cancer. So these are the long-term complications. So when you are treating a mother, you are treating two individuals at the same time, right? The offspring will get the benefit if you treat GDM appropriately in the mother. So this is one of the Patterson hypothesis. What it says is that, see, fetus have no mechanism to stop the intake of energy. Whatever comes from the placenta, it has to take. So it can't refuse. There's no refusal. So if you give more glucose or more free fatty acid to the fetus, it will take them. There will be increased insulin from the fetal, pancreas, more of the growth, and there will be macrosomia. So if you can decrease the glucose part, decrease the even fatty acid part, less energy will be going to the fetus and growth will be normal. And similar thing will happen if you give less calories to the mother, then we have small for gestational age. So in starvation you have small for gestational age, and diabetes because nutrient supply is more to the fetus and he can't refuse, so he or she can't refuse, so more of intake and more of growth and more of macrosomia. So this was the Patterson hypothesis. So what the macrosomia does is it leads to iatrogenic preterm delivery and respiratory system syndrome, and because of a decreased lung surfactant and shoulder dystocia, brachial plexus injury, then hypoxia, stillbirth, and polycythemia, hyperbilirubinemia, and irreversible sometimes cardiomyopathy. All these things can occur with macrosomia. Now, how to diagnose GDM? We have talked about what is GDM, it is glucose intolerance, what are its complications, why it occurs, we know. And we know from this point that those female who have some abnormal beta cell function or already having insulin resistance, they will be theoretically more prone to get GDM. Like obese person with diabetes history, person with previous GDM history, they are more prone, right? So how to diagnose GDM? There are risk factors for GDM like history of macrosomia, previous pregnancy GDM, ethnicity, polycystic ovarian syndrome, essential hypertension, history of spontaneous abortion, unexplained stillbirth, family history of diabetes, obesity, age group older than 25, persistent glucosuria, although this is it's a questionable kind of thing. But at least 50% of patients may not have that classical risk factors for GDM. So ADA recommends as such that we should have a selective screening, but in the Indian context it should be the universal kind of thing. So all female should be investigated for GDM in the Indian context, because as ethnicity, as race, we are more prone to get it. So GDM. So these are the criteria for GDM. You can see there are so many modifications, so many recommendations, starting with O'Sullivan, who started it. In fact, O'Sullivan started it to predict the diabetes in the mother, not for other things, not for perinatal mortality. He has done this for the predictive value of glucose tolerance done in the pregnancy for the future diabetes in the mother. Then you have NDDG, then CNC, EST criteria, ADIP criteria, WHO, IADPS criteria, then we have DIPSI criteria. So this is the criteria which we are talking. I am just pointing out 3: WHO criteria and IADP SE criteria and DIPSI criteria. DIPSI is a homegrown kind of thing, and they have Dr. Singh has done a lot of work on it, and DIPSI criteria is currently, or WHO criteria currently we are following. So it's a WHO criteria says fasting OGTT with 75 grams of glucose. If 2 hours glucose more than 140, it's GDM. DIPSI says any time of the day. Alright, nothing that patient should be fasting. Any time of the day, you give 75 grams of glucose and do blood sugar at 2 hours. If it is more than 140, it becomes GDM. IADP SE criteria is with 75 in the fasting state, more than 95 as fasting, more than 180 at 1 hour, more than 153 at 2 hours. Any of the one value, if it's significant, it called for GDM. So this is the criteria. So question comes, why in India we have separate guidelines for screening? The point is clear, as I already discussed, that Indian females are 11-fold increased risk of GDM as compared to the Caucasians. Prevalence is 16.55%, and anything more than 10% requires a universal kind of thing, right? single blood glucose measurement after glucose tolerance test, right? This is economical, feasible, can be done in one visit, and there is no need of fasting. That's the beauty of the DIPSI criteria. So it is adopted, and we are currently doing it, but many centers do take WHO criteria. You take any criteria, but the point is, if it at 2 hours it is more than 140, it's a GDM. What are the management issues? When you have diagnosed GDM, that mother has values which are 160 or 170, we have diagnosed. What are the management issues? Number 1 is patient education. Number 2 is medical nutrition therapy. Then pharmacological therapy. We have glycemic monitoring, how do you do it, and fetal monitoring, and what should be the plan on delivery. One by one. Glycemic targets, target recommended by the 5th International Workshop. Fasting glucose should be less than 95. 1 hour postprandial should be less than 140, and 2 hour postprandial should be less than 120. That's the goal to achieve when you treat the patient. Now, medical nutrition therapy, we have to achieve the normal glycemia, and this is the first thing we do. And remember it, that any dietary therapy will show its results within 1 or 2 weeks. That's the 2 weeks are required for its effect. So pregnancy is a short period. You are diagnosed at 24, 25, 6 weeks, and there's a little time. So 2 weeks are good enough. Don't wait for the response beyond 2 weeks. Start the therapy, pharmacotherapy. So what is medical nutrition therapy? Right, is the food plan should provide adequate calories intake to provide fetal and neonatal and maternal health, and achieve glycemic control goals and promote weight gain. The recommended dietary reference intake for all pregnant people is a minimum of 175 grams of carbohydrate, or 35% of total energy intake, a minimum of 71 grams of protein and 28 grams of fiber. The nutrition plan should emphasize monounsaturated and polyunsaturated fats while limiting the use of saturated fat and avoiding the trans fats. Oh, there was confusion whether it should be 35% or 55% or 60%. There was a confusion, but 47% of the total energy take should come from carbohydrate. That's the kind of middle path. It does not, increases the chance of large for gestational age, and does not increase the chances of small for gestational age. So 47% of total energy intake should come from the carbohydrates. Liberalizing higher quality nutrient dense carbohydrates result in controlled fasting and postprandial glucose, lower free fatty acid, improved insulin action and vascular benefit, and may reduce excess infant adiposity. So if you decrease carbohydrate intake, then probably you will be supplementing it with the fat. Fat is also bad, right? So if you increase carbohydrate too much, then you will be increasing the load, glycemic load, and thereby more of glucose and blood sugar will go high. So it's the compromise is 47% of the carbohydrate component should come from carbohydrates. Now, fasting urine ketone testing may be useful to identify those who have severely restricting carbohydrate to control blood glucose. Remember, ketone bodies in pregnancy, they are not good. In fact, they inhibit the trophoblast activity. Trophoblastic transfer of glucose is decreased, and trophoblast may die, and there may be, abruptio placenta also at one point of time, because trophoblast growth is inhibited by the ketones. So simple carbohydrate will result in high post-meal excursion, so avoid the simple carbohydrates, should take complex carbohydrates. Then comes the physical activity and weight gain. A systemic review demonstrated improvement in glucose control and reduction in need to start insulin or insulin dose requirement with an exercise intervention. Many exercise interventions have been tried, aerobic, anaerobic, also strength training, yogic exercises, all these things have been tried. And there's no single study that compares one exercise with the other, but recommendation is to have a exercise component to GDM. What about weight gain? Gestational weight gain of 5 to 9 kg in women with class 1 obesity and less than 5 kg in class 2 obesity, and no weight gain in class 3 obesity. Minimized combined risk for large for gestation age, small for gestation age, and cesarean section. This is a recommendation from Institute of Medicine. Now, gestational weight gain less than recommendation is better in GDM, and it is protective for LGA and did not increase SGA. So, majority of the patients who have GDM, they fall into the category of obesity. Of course, there is no data for the Indian BMI. This is the Western data, but certainly weight gain should not be that high. More weight gain means more of insulin resistance. When to consider pharmacotherapy? So you 90% of the patient, they will be happy with or they will be controlled with nutrition therapy and with exercise. Remaining 10% will require pharmacotherapy. So immediate insulin therapy is required in those patients who have developed overt diabetes or they have pre-existing diabetes. After trial of lifestyle modification for 1 to 2 weeks, if blood glucose target are not achieved or there is evidence of macrosomia on ultrasound, one should start the pharmacotherapy. What pharmacotherapy? Treatment of GDM with lifestyle and insulin have been demonstrated to improve potential perinatal outcome in 2 of the large randomized studies. All right, and insulin is the first line agent recommended for the treatment of GDM, while individual RCTs support the limited efficacy of metformin and glyburide. So, in fact, insulin is the only treatment should be given. That's the number 1 choice for the many of the organizations. Furthermore, in separate randomized clinical trials, glyburide and metformin failed to provide adequate glycemic outcomes in 23 and 28% of participants with GDM respectively. So this is what is in nutshell I have brought. And metformin, there was a even GDM treatment guidelines from the Ministry of Health. They say that metformin is there in that segment, but metformin is it is notorious in the sense that it gives, although it gives a small for gestation age babies, but later on they become obese and fat also, and they develop type 2 diabetes. So this was a study which we talked about metformin in gestational diabetes, the offspring follow-up study. That's a MIG TOFU study. This is the analysis of 7 to 9 year old offspring. The 9-year-old offspring exposed to metformin for the treatment of GDM in the Auckland cohort were heavier and a higher waist to height ratio and waist circumference than those exposed to insulin. So this difference was not found in the Adelaide cohort. So this was a MIE study was done in the Australia and New Zealand. So one cohort showed that those patients who are exposed to metformin after 9 years of their birth, they showed adiposity. They were obese, having waist circumference which was more than those who are treated with the insulin. Now, in 2 recent randomized controlled trials of metformin used in pregnancy for polycystic ovarian syndrome, follow-up of 4 years old offspring demonstrated higher BMI and increased obesity in the offspring exposed to metformin. So there is a imprinting in the womb that those who are exposed to metformin, they become obese later on in life. A follow-up study at 5 to 10 years showed that the offspring had higher BMI, weight to height ratio, waist circumferences, and a borderline increase in fat mass. So recent meta-analysis concluded that metformin exposure resulted in smaller neonates with an acceleration of postnatal growth, resulting in higher BMI in childhood. There was another point. The patient who is polycystic ovarian disease becomes pregnant, she is on a metformin, whether she should continue throughout. The randomized double-blind controlled trials comparing metformin with other therapies for ovulation induction in individuals with PCOD have not demonstrated benefit in preventing spontaneous abortion or GDM, and there is no evidence-based need to continue metformin in these circumstances. So patients who are on metformin, polycystic ovarian syndrome, becomes pregnant, you should stop after say about whenever, and the first trimester you can stop. There is no increased chances. There was one study which says that if you continue further, you can decrease the spontaneous abortion, but it is not proven now. So you can stop metformin. What was the sulfonylurea? Sulfonylurea in the meta-analysis, they don't provide anything, so should not be given. Then comes insulin. The physiology of pregnancy necessitates frequent titration of insulin. So you should give insulin. That's the only thing which many of the organization has said, that insulin is the proper therapy. Now, when to initiate insulin? That's the American College of OB. Insulin is often added to nutrition therapy when fasting blood glucose are persistently more than 95, 1 hour more than 140, and 2 hour more than 120. And IDFE says little bit lower, fasting plasma glucose of more than 90, remaining rest is the same. And DIPSI is more stringent, and it says 90, and PPG more 20 after 2 weeks of medical nutrition therapy. Now this is the recommendation by various organizations. ADA recommends a first line insulin, second line metformin and glyburide in those patients. Glyburide is glibenclamide in those patients who cannot safely take insulin. So American College of OG of scanning, it's insulin and metformin for women who decline, cannot safely take insulin or cannot afford insulin. That's the thing. And what about NICE? They say metformin only if mild fasting hyperglycemia and no complication, and alternative first line insulin, and Diabetes Canada is insulin, and similarly DIPSI is insulin. Now how to give insulin? Of course this is a specialist kind of job. It has to be done by a trained person who is dealing with GDM, or some physician who is routinely dealing with GDM, or endocrinologist, whatever. So which insulin? That's the point. Any insulin can be given. No insulin, because insulin does not cross the placental barrier. So it does not cross placenta, so any insulin can be given. The only thing is we should give insulin those insulin who have randomized controlled trials. So there are insulin in the market which are there, can be used. There's nothing of that sort that one cannot give this insulin or that insulin should be given because it is. So only thing is what we say is that insulin which have studies with it, probably that's better. But there is nothing that this particular insulin is bad for pregnancy, nothing of that sort. So you can use Aspart, Lispro, regular insulin, NP insulin, Datamar insulin, Degludec, even Glargine also. Although there is no study, that's the problem. Glargine can be given. There's one study which says Glargine can be safely given. So any insulin can be given. Why I'm saying it? Because insulin does not cross the placental barrier. It is not affecting the fetus, so it can be given. So how to assess glucose in pregnant ladies? What about the HbA1c? Role of HbA1c? What is the role of fructosamine? What is SMBG? Which is the best thing? The best thing is here SMBG. Why I'm saying so? Because of the HbA1c is because of rapid cell turnover in female, RBC turnover, HB will be lighter, it will be low as compared to the non-pregnant female. So target here will be as less than 6%. If you want to see the response, it should be less than 6%, and it should be done not 3 monthly. It can be done every month, because HbA1c, if you see, it indicates almost 40 to 50% of the contribution in the HbA1c result is coming from the last 1 month, and the first month, that is the of the 3 months, last month has the largest contribution, middle month has 30% contribution, only 10 to 20% contribution come from the first month. So one can do one HbA1c every monthly to assess the response to the therapy. Fructosamine is the one thing which assesses the control over the 2 weeks, but it's not validated that much. So one can use it, but validation is not there. SMBG, how frequent one can do, one should do. SMBG, ADA recommends more than 3 times a daily. Those who are insulin probably require more than 3 point also, sometimes 7 point also. And disadvantage, of course, frequent pricks. And currently what we are doing is we are applying CGMS devices to the pregnant ladies and sensors also. So we come to know, although that's not the ultimate, one has to check blood sugar with glucometer also, but one of the methods where the pricks are less and you assess the glucose by a reader also. So CGM devices have come in handy at this point of time. So what is the optimal time for postprandial glucose measurement rated according to clinical outcomes? It's not 2 hours. Surprisingly, it is 1 hour. So based on the practical experience and dietary recommendation, authors prefer a 60-minute interval, as patient can calculate this more easily and can have more freedom to eat the recommended number of snacks. And in one of the studies, which I am not quoted here because of the time constraints, 1 hour in glucose is more predictive of perinatal complications and mortality as well as morbidity. Now, outcome of GDM treatment, what happens? A recent Cochrane review including 8 randomized controlled trials in GDM treated with diet and insulin reduced composite outcome of perinatal morbidity by good 68% compared to routine antenatal care. Treatment was also associated with reduction in microsomia, LGA, that is large for gestational age, and preeclampsia, but increase in the intensive care need. That's the only flaw. Now, fetal monitoring from 26 weeks, every 2 weeks we have to see the liquid volume, abdominal circumference to know whether the patient is developing macrosomia. And intrapartum, attention to labor pattern, as phallopelvic disproportion may indicate fetal macrosomia. If steroids or beta agonists are given for the lung maturity, then we have to increase the insulin doses. Skip morning insulin on the day of induction of labor. Usually there is no need of insulin while labor. Early blood glucose monitoring during active labor with insulin drip if necessary. Notify pediatric person a patient has poorly controlled blood sugar, antepartum or intrapartum. What about the postpartum? For all GDM patients, perform 75 grams 2 hours GTT to know the to rule out the gestational, pre-gestational diabetes. And most common recommendation is for primary care physician to repeat it. And if normal, 2 hour OGTT every 3 years should be done. Metformin and glycolides are secreted in breast milk and are therefore contraindicated. Breastfeeding plus insulin therapy may lead to severe hypoglycemia when the patient is breastfeeding at that time. Preventive measures are reduce basal insulin and give carbohydrate intake prior to breastfeeding. For babies, start early breastfeeding, commencing at 1 hour, and check blood sugars. Anything less than 44 is considered as hypoglycemia in the neonate and treat accordingly. Who will progress to diabetes? GDM patient, who will progress? Those who have a large waist circumference or BMI, autoantibodies, diabetes at earlier gestational age, gestational requirement of insulin quite high, and higher FBG and higher blood glucose on OGTT, neonatal hypoglycemia, recurrent GDM, all are candidate, and who will progress to diabetes later on. So in conclusion, this is a graphical abstract of the conclusion that there are preconception risk factors like obesity, ethnicity, nutrition, physical activity or genetic predisposition which is there, which predisposes to GDM. And in pregnancy what happens, there is increased glucose, triglyceride, free fatty acid, gestational weight gain further accentuate these things, and there is increased maternal insulin resistance mediated by epigenetics, placental hormones and cellular inflammation. What are the short-term maternal and neonatal complication is preeclampsia and obstetric interventions more often required in female. And for the neonate fetus, it's a stillbirth, congenital malformation larger for gestational age, preterm birth, birth trauma, hypoglycemia, hyperbilirubinemia and respiratory distress syndrome. And long-term maternal and offspring outcomes are there is dysglycemia, type 2 diabetes, cardiovascular disease as well as obesity in mother as well as the offspring. So with that, I finish my lecture here. Thank you for the patient hearing. Thank you.
Thank you, Dr. Parminder, for an excellent talk. And I would like to extend your talk for 5-6 minutes and to apprise our audience about the utility of pre-pregnancy counseling for prevention of diabetes. Since we have time, we want your intellect and your orator skills to apprise our audience about the utility of pre-pregnancy counseling in prevention of gestational diabetes.
Just to add to that, you see, this use of metformin in pregnancy, as you mentioned, this Auckland study and then this Australian study, I think this is something new to me, at least I never knew about it, you see, and thank you for that. But the implication of that, I think in the future, probably all those ladies, so in the reproductive phase, I think probably we should avoid using metformin in those patients, those ladies.
See, so first Dr. Vitull's point that we should pre-pregnancy counseling of the patients, right? It's a deficient at this point of time, right? And probably what happens after marriage, there is a partying and all those things. Every female tend to gain weight unless one is very conscious about the weight. So weight gain is a major determinant. Increasing in BMI is a major determinant of dysglycemia in the pregnancy. And we should, in fact, those patients who have a family history, those patients who are obese, if they are coming to obstetrics for their consultation, or for that matter, if they are coming to you when they are married, but they are coming with their father-in-law, mother-in-law, and you can comment upon them that please reduce your weight to have less chances of GDM during pregnancy. That's one of the things we can do as a social cause. And the remaining things about the, as Dr. Saab saying, is metformin, this is news to him. This study was, many times when this study came, mixed study even came, then metformin, many of us started writing metformin. But then the follow-up data came, that we came to know that probably it's not as good as we used to think. Still, presently also, NICE says that metformin can be given when fasting hyperglycemia is there, postprandial is good. Alright? So, NICE says that one can give. And even, Health Ministry, GDM guidelines have metformin still there. Although the major others, ADA and other things, they have taken off metformin as first-line therapy, and for them it's a lifestyle modification plus insulin. That's the only thing.
So I think I must congratulate you, because now GDM is being considered to be the root cause of NCDs in the population, and we are providing suboptimal care for GDM. So I think for preventive part, that after a female is diagnosed as GDM, the postpartum care is also important for prevention of diabetes and other NCDs in those ladies as well as in the offsprings. So thank you very much, Dr. Parminder. If you want to touch upon some points.
Just to add that probably our diet is, almost 70% of calories come from the carbohydrates. Probably that restriction has to be done. It has to be close to 47%, or you put it 50% if you want to remember from that account. So carbohydrate limitation will decrease the spike of postprandial glucose. And just don't have this idea that what I am talking is ultimate. Probably we are dealing with heterogeneous population, right? When we talk about GDM, we are focusing on postprandial. You see, all things are postprandial glucose, postprandial glucose. But there are many patients in whom the fasting will be close to 100 or 110 and postprandial is 130 only. So this indicates that there is a heterogeneous population. What I have talked is one single kind of population which is having the postprandial hyperglycemia. So don't forget that it's a heterogeneous population, and some patient may be having predominant insulin resistance, but later on in historically GDM is an insulin secretory deficiency. It is a insulin secretory deficiency, because in every pregnancy there is 200 to 400 increase in the insulin resistance in every pregnancy. Only those who can't produce enough of insulin from beta cell, they develop GDM. So this is just in the society also we have impaired glucose tolerance as such. So impaired glucose tolerance, milder degree, impaired glucose tolerance, and pregnancy stress manifest it as GDM. So take it like that, and take it as it's a heterogeneous. Don't. My only problem with the DIPSY criteria always remain that it is a targeting on the postprandial. It's not looking at the. I have a favorable response to IAP criteria which has a fasting as component. So.
Any other question from the audience, please? So thank you, Dr. Parminder, for
thank you, Dr. Vitull, for extending the invitation, and really nice to come here, and feeling very good. The place and the other things are so good. Thank you so much.
So it adds to the glamour of MAPICON when with your presence. So you are one of the first endocrinologists of Punjab, and we are really honored to have you here. Thank you very much. Now I invite Dr. Arun Thapar.